Everyone, this is Dr. Romain Johnson. He's going to be talking about quality and safety for tracheostomies, and I'm excited for this talk as well. Thank you.
And then what time do you want me to start?
You can start now. Go ahead, take the full hour. You'll see the numbers. There's 12 on right now. You'll see a few more people join in, but just go ahead and get started.
All right, sounds good. Well, welcome everyone. This should be, I guess, mostly pediatric otolaryngology fellows, but there are probably some residents, maybe even some medical students on board as well. Most of you probably don't know me. My name is Romain Johnson, and I'm at UT Southwestern Medical Center in Dallas, and I primarily work at Children's Medical Center Dallas, which is the standalone hospital that we're affiliated with. And that's where I have my practice. And I do a little bit of everything except ears, but a heavy focus on airway management. And then one of the things that I'm particularly interested in is the child with the tracheostomy. And I probably spend half of my clinical practice, maybe even more, just taking care of kids with trachs. I don't have any, let me swap screens. I want you guys to see this screen. Okay, so I don't have any disclosures and no conflicts of interest, which some days is very disappointing to me, but it is what it is. So I think about this quote a lot. The means represent the ideal in the making and the end in process. It basically means that the way you go about something will determine the end. You know, there's always this debate, at least in politics, that the means justifies or the ends justify the means. And I think Dr. King suggested that that's not true, that the way you go about doing something ultimately will produce a certain end. And if you want a sort of a just end, you have to do just means in order to get to that end. And I think about that just personally as a physician, and the way I go about my practice will ultimately determine the end result and the clinical outcomes. And I think quality and safety, there's a lot of that involved with quality and safety as well. If you want a particular end, better postoperative outcomes, then you have to think about the means by which you're trying to achieve them. And if you don't align those means correctly, then you won't necessarily achieve the ends you're looking for. The other one of my favorite quotes is by Mark Twain, and he says, "My books are water, those of great geniuses are wine, everybody drinks water." And I think the idea is that, there are a lot of geniuses among us, especially in the otolaryngology world, a lot of smart people, and many of you are among them. I guess I'm among them too, but I consider myself to be more practical, and that my goal is not to be like a Michael DeBakey type person. Instead, I just want to grind and just do things that everybody can do. So even in the way I try to teach surgeries, I try to give practical advice on how to just become a better surgeon, how to go about this operation, how to approach the patient, and where it doesn't involve some extraordinary skill set. It's just working with the things that you have in order to be better. So I have some unsolicited career advice, since we're all like stuck on Zoom, and I guess we're starting to ramp up and see more patients. And I may not have the opportunity to meet a lot of you. I don't know when the next time we're going to have meetings. We're probably going to be doing a lot of Zoom meetings for the foreseeable future. So this is my opportunity to kind of tell you what I think you should do for your career. And again, you can take it as you want. But one of the things I learned is that you have to learn how to manage yourself. And this article written by Mr. Drucker is something I read years ago, and it is still true today, that in this world that you are about to inhabit, or you do inhabit, most of the work is on yourself. How you go about your business is going to be on your own. There's not going to be a lot of people kind of watching you and telling you like, oh yeah, you need to do a tonsillectomy a certain way. You need to do this a certain way. It's more like you got to figure things out for yourself. And so learning how to manage yourself is just an important piece to your practice. In this article, I recommend you read it. I even ask a lot of the residents and medical students and fellows who are interested in working here, I'll ask them some of these questions just to see if they've even thought about these things. And so the first thing, I think you really do want to focus in on how you perform in results, right? That's what's going to count. The bottom line is, did you produce what you were supposed to produce? Are you able to see a certain number of patients? Are you able to do a certain number of surgeries? Are you able to do those surgeries well? If you're in an academic practice, are you writing? Are you presenting? So you really do want to focus in on what are your results. And then a big part of that is learning how you perform. How do you get things done? And so that's a question of what are your strengths? Are you really good at writing? Are you really good at speaking? Are you a strong reader? Do you work well with others? Or do you prefer more quiet time? You need to be able to answer all those questions. One of the things I'll ask people is, how did you learn how to do a tonsillectomy? We all know how to do a tonsillectomy. Certainly, I hope we all know how to do a tonsillectomy. But how did you really learn how to do it? Because it's not something that you came in able to do. And so I'm sure there was some bumps in the road. There had to be a few tonsillectomies where the tonsil fell apart. There was lots of bleeding and it was a mess. And so when you reached that point, what did you do to get better? Did you, open up a book and say, let me read a little bit more about tonsillectomy. Maybe there's some pieces of information I'm missing. Did you ask someone to show you, like, hey, can you show me how do you do a tonsillectomy? I want to watch and learn. Or did you just sit back and watch? You didn't ask. You just kind of sat to the side and said to yourself, you know what? I'm going to watch this person do the tonsillectomy. And I'm going to learn by paying closer attention to what they're doing. There's no right answer, but you need to know for yourself, how do you do it? Because that's going to go a long way in figuring out how do you overcome the rough spots that are going to occur in your career. What are your values? And again, that's not a question of ethics, right? We shouldn't steal, we shouldn't lie, we shouldn't talk behind people's backs. Those are ethics. Values are things like, I really want to work for a department that emphasizes research and innovation versus I want to work for a department that values lots of cases and being strong clinically, and maybe the research piece and the laboratory piece isn't as important. And then, of course, figuring out where you belong, what type of places you fit in, those are critically important. And then wherever you go, you need to ask yourself, what can you contribute? And a big part of that is what's needed. And then how can you help them, your colleagues, your department, your job, your practice? How can you help them achieve what's needed? And so the last piece in terms of unsolicited advice is, there's something called scholarly activities. And if you're going to do academic medicine, you're going to be judged by scholarly activities. So since you're going to be judged by how much scholarly activities you do, you should know what they're judging you on. What boxes do you need to check? And so these are the boxes that need to be checked. Typically you want to have some PubMed published articles, peer-reviewed in the laryngoscope and otolaryngology and International Journal of Pediatric Otolaryngology. You want to have some of those. If you can get 4 a year, that's kind of the basics. That will be good. You want to be giving presentations at conferences. So that means you have to submit abstracts and posters at conferences. Now, who knows what's going to happen over the next year or two, but I think there's still going to be opportunities for virtual presentations. You should be giving lectures and grand rounds. You typically won't get invited to give grand rounds until you have an academic record, but you can give grand rounds at your institution, and you can give grand rounds locally, and that counts. Think about writing a chapter textbook, once a year, maybe once every 2 years. They're not a lot of fun, but so I wouldn't do a bunch, but doing 1 or 2 is definitely significant. If you can get grants, that's awesome. Think you don't have to get an NIH grant. There are a lot of local grants that you can get. But think about, are there small grants? Is there external funding that you can provide? And then what role are you providing in terms of peer review? Everyone should be doing some peer review for some journal. It's an important part of being a good citizen. And ask yourself this question: if someone was to review your paper, wouldn't you want someone like yourself to do it? So that means you need to be one of those people doing it as well. And again, I think all of us should be organizing courses and teaching as much as possible, is teaching residents, fellows, other physicians. And these are things you can do at your home institution. It doesn't have to be at the academy or in a triological society. You can do that within your home institution. All right, so I'm going to talk about tracheostomy. I'm going to talk about the benefits of an airway program, and I'm going to talk about how a hospital and the program can partner to improve processes and outcomes. So in the United States, we perform about 5,000 pediatric tracheostomies a year. 43% more or less are in kids under 2. So a big part of our practice is kids under 2. Neonates represent about 15%, and that means there were neonates on admission. They may not have had their tracheostomy within the first 28 days of life, but they were admitted to the hospital within the 28 days of life, and then you went on to perform a tracheostomy in them. Males tend to be more affected than females. African Americans are disproportionately affected. If you look at census data, there's about 13 to 15% of the US population, but roughly 20 to maybe even 25% of the trach population. And then premature infants are about 10 to 15%. So it's important because trach kits cost a lot of money. If you look at tracheostomy patients, they're the highest aggregate cost for all pediatric non-birth admissions in the United States in 2016. They represent about 4% of all inpatient costs, but only 0.1% of all pediatric stays. And we've experienced this ourselves. You know, these patients stay in a hospital a long time. They're often very sick with a lot of comorbidities. And so it's really important to know various ways to improve their quality. Like I said, the length of, So if you look at cost, which is one of the most important predictors of quality that the hospitals are interested in, as well as length of stay, those are the things that are going to be interacting and driving each other. So length of stay kind of drives cost. If they have surgery, that drives cost. But length of stay is the big one. And if you look at the KID database, about 72% of a hospital's cost for an admission is going to be due to length of stay, and if they had a major operating room procedure. For tracheostomy patients, the mean length of stay is 61 days. They have a bunch of procedures while they're in the hospital, and on average, they're about $590,000 in total charges. Costs will be a little bit less, but it's still pretty expensive. When we look at Children's Medical Center Dallas, or Children's Health, as we like to call it, we have about 500 tracheostomy children in our registry at any time. We have a dynamic registry, meaning patients enter and leave depending on their trach status or if they're alive. But at any time, we have about 500 kids. We do about 50 trachs a year. Again, we're mostly male, a lot more African Americans and Hispanic kind of representing the population of Dallas-Fort Worth. Most of our kids are vent dependent at discharge. So chronic lung problems, respiratory failure, they make up the bulk of the reasons we put in tracheostomies. The mortality rate over the lifespan of a child with a tracheostomy is about 15%, and about 5% will have in-hospital mortality on their index admission, meaning that the admission that we put the tracheostomy tube in, about 5% of them never get discharged from the hospital. Our decannulation rate is 25%. So that means roughly if you take out the 15%, about half of our 15% of patients who pass away, about half of our patients really never get their trach out. So, you know, once you put a tracheostomy tube in, the majority of patients keep their trach long term. And the majority, really the overwhelming majority of them, are severely disabled. Now, it's hard to define what constitutes severe disability. It's kind of like art. You know it when you see it. But generally, these patients have the diagnosis of global developmental delay. So again, for us, most of our trachs occur within the first year, you know, almost 70%. And then we'll have a few more as you get older. We'll even have some in their 20s, mostly trauma, or maybe an older kid who came in with another reason and developed a complication. And if you look at our population of trach patients, you see it's mostly young, but we do have quite a few who are in their adolescence. And then we even had a few that were kind of older that we haven't been able to transition to an adult practice yet. So I like to use Kaplan-Meier survival analysis when I look at trach patients because, you know, they're alive for different periods of time. Also, they're decannulated at different periods of time. And also the follow-up is at different periods of time. In this graph, I think the important thing here is the median survival. If you look at patients who die, they die pretty quickly, like half of them within the first year. And usually like within the first 6 months, the majority of patients will pass away who have a tracheostomy. And then if you look at decannulation, again, we're able to decannulate about half our kids before 3. And then by 5, probably 80% of our kids who are going to be decannulated are decannulated. So why is the care of pediatric tracheostomy patients important? So it epitomizes the challenges of quality and safety in children. You have high risk, clinically vulnerable populations. There are a lot of processes that have to be performed correctly in order to avoid devastating complications. Think about changing a tracheostomy tube. Many of you, particularly those who are fellows or going to be fellows, or who are higher level residents, I'm sure you have either experienced or have heard of a trach change going bad and a patient developing a devastating complication, if not expiring. And that's such a simple process, right? Changing a trach. But yet, if you don't do it right, if you don't have all the appropriate things lined up, you can have a devastating complication. And of course, as I mentioned earlier, they have very long lengths of stays and very high cost. Think about also all the people that are involved in their care, right? So you have these high-risk patients, you got respiratory, you got ICU, you got pulmonary, you got speech, occupational therapy, home nursing, lots of turnover in the staff. How often do you guys go to the ICU? Or maybe it doesn't happen at your institution, but one week it's one ICU team and the next week it's a totally different ICU team and there's a whole new plan. And so everyone's got different levels of skill involvement. You have some places where they're very comfortable with trachs and you have other places where they're very uncomfortable. And so all these things start to come into play and create this quality improvement, quality and safety minefield, if you will. All right, so I'm going to read this to you. Recent studies of large formal organizations that perform complex, inherently hazardous, and highly technical tasks under conditions of tight coupling and severe time pressure have generally concluded that most will fail spectacularly at some point, with attendant human and social costs of great severity. The notion that accidents in these systems are normal, that is to be expected given the conditions and risk of operation, appears to be as well-grounded and experienced as in theory. Yet, there's a small group of organizations in American society that appear to succeed under trying circumstances, performing daily a number of highly complex technical tasks in which they cannot fail. And then she goes on to say, we're studying a few of these organizations. Interesting, one of the organizations is the Pacific Gas and Electric Company. And I don't know if you remember a year ago that PG&E made a mistake and resulted in a wildfire that destroyed hundreds of homes, resulted in millions of dollars in damage, and ultimately led to their bankruptcy. And that's the idea behind why these organizations can't fail. And then she termed, Dr. Roberts, she termed these organizations high reliable organizations, HRO. And if some of you who are involved in quality and safety have probably heard this term before. And it's the idea that care that is high quality, safe, and efficient. And these HROs can do these tasks without error for long periods of time. So if you think about an aircraft carrier, there's lots of processes, they have lots of staff turnover, they have various levels of education, and yet they're able to have these flights take on and off and not have any major accidents for long periods of time. And this is where a lot of people think we need to head towards in terms of quality and safety innovation in healthcare. And the idea is that, okay, technical advancements like the pulse oximetry, that makes a huge difference. Now you don't have to wait for the patient to turn blue or gray before you stop that, before you stop your procedure and intubate. Now with the pulse oximetry, you can find out very quickly. Another piece, obviously, is standardization of processes. So making sure we always do a timeout, and we make sure that we always do our timeout and we say certain things, and that can improve your quality and safety. And then the next level, and the level that we all hope to get to, is the high reliability organization, where now it's frontline behaviors and practices, leadership, and a cultural shift towards teamwork and care coordination, where kind of everybody's working together and it becomes more intuitive, if you will. So in 2015, we looked at our tracheostomy patients and we saw that they were the highest utilization patients in the hospital. We had a few patients who were in the hospital over a year after their trach was placed. A lot of decannulations, and there was very little coordination between inpatient teams and outpatient clinics, and we weren't doing a good job of learning. People weren't getting more comfortable taking care of tracheostomy patients. So we created a virtual center for these patients, and we have operational support. We use Epic to build, to have electronic medical bill, record bills. We do marketing in order to let people know that what we're doing, financial analysis to see if our program is working. And our primary goal of the team was to reduce length of stay. That was the big metric, but we have other metrics too. And so in roughly late spring 2018, we formalized our team, and it's actually been, we have new team members now, but the goal is to have physicians, nurses, respiratory therapists, business managers, all kind of working together on this team to standardize processes, help with learning and outreach, help with marketing, and then develop outcome measures and make sure those outcome measures are constantly being improved upon. So there's a medical director, that's myself currently, and we have nurse specialists. One of our nurse spans both inpatient and outpatient, and then we have another one who primarily works on the inpatient side. We have respiratory therapists, speech pathologists, we have our program manager, coordinator, case manager, and social workers. All these individuals kind of working together to help take care of children with tracheostomies. So I like to say this: standardization plus situational awareness leads to quality. So if you standardize, if you want quality and safety, you have to standardize your approaches. It's going to be very difficult to do it without standardization because you won't know where your blind spots are. You won't know what works and what doesn't work if you don't have a standard approach in which you can go back to periodically and say, okay, we always, put trach ties on, or we always suture the trach to the skin. Is that necessary? But at the same time, we have to have situational awareness. The idea that, yeah, you have the standard approach, but sometimes the situation, you got to change it up a little bit. You got to be able to know when, okay, yes, we always get this particular lab, but something's not right. Or maybe we never get this lab, but something's not right. Let's get the lab this time. So having situational awareness and both of those things combined will help lead to quality. The other thing, of course, is process improvement is quality improvement. If you want to improve quality, you have to improve your processes. And so we looked at all our processes for tracheostomy, and you should do the same. How do you place a trach? What are your post-op instructions? What constitutes your education? How do you deliver education? What constitutes post-op care? How are you going to follow up your patients? What are some of the sick plans that you should have? How do you let families know when things aren't right and they should come in? And then, decannulation, and then also transition to care to adult practitioners, since many of your trach patients are going to live most of their lives with the trach. So for us, for trach placement, we use the FlexStem Bavona TTS standard trach for all our placements. Again, situational awareness. Sometimes we put a Shiley in, sometimes we'll put a Traco in, but this is our standard trach. We tend to go with a pediatric length, and we use stay sutures, but we use Velcro ties. We don't use the twill ties, and we don't suture the trach to the skin. The reason we don't do that is just I found it's easier to do trach changes emergently if you don't have to use suture scissors to cut the ties or the suture. And it's pretty secure. We do a DLB, direct laryngoscopy or bronchoscopy with placement, and it's to check the trach length to the carina, and then also to check the larynx and the subglottic airway to see if there's swelling, edema, granulation tissue, because we want to know if we can use a speaking valve, and if they have subglottic stenosis or what appears to be, could be subglottic stenosis, we want to keep that in the back of our minds to check again in the future. Everybody gets a chest x-ray, and we have Epic builds so we can track all the steps, so we can go back and we can look at the data and see if we're being consistent. So our trach education starts before the trach is placed. We have a trach team that goes and meets with the family. We do a consult. If there's any concerns at that consult, we typically will have a family meeting where we'll get the ICU, anesthesia, palliative care, social work, pulmonary, and we'll make sure that everybody's on the same page with the kid with the trach. Because I'm sure, as you guys know, there are a lot of neurodevastated kids with trachs, and whether or not we should be placing trachs in all of these children is, we don't know, but we're trying to get better at really asking families and letting families know that, this kid may never have the trach out, they may never walk, they may never talk. So let's have a real conversation about quality of life. And then we'll leave a note, and then our first formal trach class is at the same time as the tracheostomy tube. One of the things that we discovered is that the delay in trach education was causing delay in discharge. We couldn't do anything until certain boxes got checked. So now most families are there the day that we put the tracheostomy tube in, so we have them do the trach class that day. And then, of course, we have storyboards and checklists to check competencies and all those things. And our hospital is a little bit unique. We have a acute care rehab hospital. It's called our Children's House. So we discharge the majority of our patients to our Children's House, and there they receive further trach education, further vent education, and so they don't necessarily go straight to home, and that does help with our discharge planning. This is just another picture. It's kind of on the back of the previous one. And it's just, we give it to families so they kind of know, like, okay, you're going to have a pre-trach meeting, then you're going to have your surgery, then you got class 1, class 2, then CPR, and then just kind of lets them know what's ahead. We've updated this now to include simulation. With the COVID-19, we had to put that on the back burner. But now we're going to have, as a part of our trach education, all families will go to a simulation where they learn how to manage certain emergencies. If the trach falls out, the trach is plugged, if the vent line has got water in it, those sorts of things to help families. So once they're discharged from the hospital, try to see every patient within 30 days after discharge. I do every 3 months, the first 24 months after the trach is placed. And then once you get past that point, I'll go about every 6 months up to 12 years. If insurance allows, I'll do once a year once they're older. And then we start transitioning 18 to 21. We try to use a one-way valve as soon as possible. We'll measure the pressures of the tracheostomy tube, or we call transtracheal pressures. And if they're okay, then we'll start one-way valve usage right away. If they're not okay, then usually we'll do a DLB. I'll look at the airway and see what's wrong. Now, some patients who are on a ventilator, their vent settings are too high and we can't do the one-way valve. But as soon as they're on an appropriate vent settings, we'll try to do it right away, because you can use the one-way valve on the vent too. A lot of kids don't get hearing tests. This is something else we discovered as we started doing more quality and safety for these kids. Almost all trach kids are at risk or at higher risk for delayed onset hearing loss, according to the Joint Committee on Hearing. So all of these kids should be getting follow-up hearing tests, most within 6 months, but certainly within 12 months, even if they pass their newborn hearing screening. And of course, we have a lot of patients who failed their newborn hearing screening, but everyone gets so caught up in the trach, and obviously the kids are also very sick, that people forget about checking hearing. So we're very aggressive when we see them on an outpatient basis, like, okay, when was your last hearing test? And all our clinics are multidisciplinary, pulmonary, speech, respiratory, dietitians, ear, nose, and throat, nurses. We try to make sure all our clinics have multiple representation in them, so kids can really do one-stop stopping. So we develop sick plans that we can give to the family, and they're also good for the home nursing. Almost all of our kids have 168 hours of nursing at home. They get 24 hours nursing, particularly the ones under 2 who are still on the vent. And so now they can use these action plans. Okay, how's your kid doing? They're having a yellow zone kind of day. And so, well, this is what you do when they're in a yellow zone kind of day. And of course, if they're red, this is what you need to do. And we have these for breathing, secretions, stoma, for all of those things. So now the families can kind of get a feel for what to look for. For decannulation and adult transition, right now we're doing polysomnography for both ventilation cessation as well as decannulation. Looking at the data, it's interesting, maybe compared to just 48 capping trial, doesn't seem to matter. Like you probably could just go with 48-hour capping trial instead of polysomnography. But I'm looking more closely at that data. Hopefully we'll have some things to present at the next year's meetings. Knock on wood. I get a lot of sleep studies after decannulation because I have a lot of borderline kids. Maybe I'm too aggressive with my decannulations, but it's just a lot of kids have borderline airways. When you take the trach out, they have tracheal stenosis due to their tracheostomy tube. They have cerebral palsy and other issues. And so I get a lot of sleep studies, and I find quite a few of them will have sleep apnea after the trach is out. And then you have this situation where, okay, should I have taken the trach out? I don't know. We're looking into that. And then adult transition, we're still trying to work out details. Right now, we're trying to send patients to Parkland, which is the Dallas County hospital for patients. And then there's also a UT Southwestern has a clinic as well. But you can imagine a lot of these patients are on Medicaid. So it's difficult to get them into certain systems. Parkland tends to accept everyone, except if you don't live in Dallas County, then it becomes another difficulty. So how do we track outcomes? Well, again, we use something called the Balanced Scorecard. And so the Balanced Scorecard kind of helps you align your budget with your strategic objectives, but you can use it in other ways too. And so the idea is that, okay, so you got this vision, you got this strategy, and then, okay, financially, how do you need to succeed financially? What are your business processes? What business processes must you excel at? So if you think about, for us, it's like, okay, what do we need to excel at? Like, we need to make sure patients follow up. We need to make sure that trach education occurs on time, that kind of stuff. How do you learn? How do you go back and figure out what you're doing and make it better? And then how do you appear to your customers? And, you know, customers aren't just your patients, but they're also the ICU, the pulmonary referral doctors, other NICUs and hospitals in the region that rely on you for services. So how do you want to look to all of them? So we kind of use this scorecard to build our what we call our Airway Balanced Scorecard. And this is what it looks like. So we look financial strength, we know what are our costs per case, how many patients would come from outside of our primary service area, what are the 30-day unplanned readmission costs, you know, what is our post-tracheostomy length of stay. In terms of clinical excellence, we want to make sure post-surgical length of stay, what is that? What's our screening bundle rate? That's making sure that speech has been consulted. We got a hearing test, those sorts of things. Are we keeping patients coming back from the to the ED after discharge, and accidental decannulation? And then you guys can kind of see the rest. And then we used all of that to build a scorecard and our dashboard. And so this is kind of what the dashboard looked like in 2019. And then like things like red and green are based on our baseline year. So if we're a certain percentage points or days or whatever it happens to be above our baseline, then we're in the red. And then if we're below it, we're in the green. And then eventually we'll have to pick a new baseline. We'll probably roll into 2019 or 2018 and use that as our new baseline. And then we'll compare our numbers to that. But I can pull this up at any time and I can kind of see what's our post-surgical length of stay over the course of a year and figure out, okay, are we in the red? And then if I look at the months that are in the red, then I can go back and look at those patients and see like, okay, was anything special about them? This is trend lines just to kind of show that we've started to see a downward trend as our trach team got more operational and our post-surgical length of stay over 2018. And then you can see in 2019, we had a lot more greens than reds compared to 2015 and previous years. And in 2020, so far so good. I think that's going to change. We got a kid that's been in the hospital a year who needs a trach. So we'll see what happens. And then our trach to first education, again, you know, really able to decrease that to 1.45 days, where I think in 2015, it was more like 10 days. And so gotten really good at that. So for decannulation, we did a variety of things. We trained the staff, we created reporting tools. This is kind of like what we'll put in kids' rooms now to give to sitters, because they're people who usually sit with kids, so they're not by themselves. And they'll say like, okay, I like to pull my trach and G-tube. I like singing, clapping, peekaboo, and, you know, kind of educate to say, okay, keep an eye on this kid. And then we have a reporting tool where we can look at accidental decannulation rates per 100 tracheostomy days. And then the latest graph does go out a little bit further. We did go back up a little bit, but we still are below our baseline level. And again, that sitter education seemed to make a big difference. Costs are tough because you also have to look at the inflation. So making those adjustments and figuring out what the true costs are is more challenging than I thought it would be. But overall, it looks like, particularly in some areas, we've been able to get our costs down. 2019 data is coming on board. It looks very similar. That's in effect, we've been able to sustain getting our costs down in some areas like the heart and pulmonary and ENT. But certain other areas still kind of like certain other ICUs, they're still pretty high. And then once you have better data, you can do better analysis, you can get better targets. So going back and looking at our data, I was able to see that this is a regression analysis. I looked at hazard ratios. And in this instance, a hazard ratio, if it's greater than 1, that means their length of stay is extended. And then, sorry, it's the opposite. If their length of stay is less, and if it's less than 1, their length of stay is greater. So one of the things that we discovered looking at our patients was 2 things. One, we really need to distinguish between complex patients and patients that aren't complex. So for us, complex patients are heart patients, septic patients, and patients that require a TPN. Those patients tend to stay in the hospital much longer than your standard craniofacial kid that gets a trach. And the other kids are the kids that are on a vent. If they have to be put on a vent, they're going to be in the hospital much longer. But the thing that I also discovered was it also depends on where they are in the hospital. So if we looked at different service lines like the NICU and the PICU and the CVICU, there was a lot of variation in those areas. So if a patient got a trach in the CVICU, their discharge, even if everything else was relatively the same in terms of level of comorbidities and how sick they appeared to be, they tended to be in the hospital much longer. Same thing for like the NICU, where maybe the PICU and pulmonary seem to be much better at getting kids out the hospital, even if they were really sick. And then the other thing was the ventilation. Putting kids on the vent, there's a lot of variation in kids being ventilated. And you guys see this. Some kids require very high vent settings and some kids don't. And so you have to be able to account for that in your understanding of discharge, length of stay. And so this is just a figure of that previous graph. And it just kind of shows that if you have a kid that's not on a vent and not ventilated, they get out the hospital pretty fast. Within 100 days, they're all out the hospital. But the other kids, they're in the hospital much longer, and there's not much difference between them. So you take a complex kid that's on a vent and a complex kid not on the vent, they're about the same. But if you take a non-complex kid and put them on a vent, then they all of a sudden start behaving more like the complex kids. So I think our next area of focus is really going to be looking at ventilation, and then also can we reduce some of the variation between the different ICUs. We use Epic to track our kids. So there's something called episodes of care. If you designate an episode within Epic, now everything that happens to that kid until you end the episode will get tracked by Epic. It's much easier to pull the data. This is how we're able to pull all the data for our dashboard. It's because they're in an episode. If we didn't do that, it would be a little bit more challenging. And then obviously we do a lot of advertising and we try to let people know what we're doing to keep our names out in the world. But I think at this point, people kind of know, consult the trach team. They'll help you. So other things that we're looking at now is just money. You know, no margin, no mission. You're going to hear that a lot. And if you haven't heard it, you're going to hear it. And it's the idea that if you don't make a certain amount of money at the margin, it doesn't matter what you want to do. You're not going to be able to do it. So you can have the best missions in the world, but you got to have enough overhead, you know, you got to have enough of a margin to keep things up. And so figuring out what our margins are is pretty challenging. I can tell you that it often comes down to their insurance. If they're on Medicaid, if you can get them out the hospital fast, you'll make a margin. If they're on commercial insurance, it doesn't matter. You'll make a margin on them no matter what. And you can have, if you have 50 trach patients and 10 of them are commercially insured, that can be enough to have a profit, believe it or not. It's weird. Maybe those things will change in the future, but that is what it is now. Other things you can do is make sure you have other data sources to look at, not just your own in-house data. So the Pediatric Health Information System has a tracheostomy scorecard. It's approximately 44 children's hospitals, and you can compare yourself to other children's hospitals. The American College of Surgeons also has a pediatric NSQIP tracheostomy-specific registry. We're not a part of it at Children's Health. I think we're thinking about joining it, but you can also use that to compare your outcomes to at least the other hospitals within the NSQIP if you're a part of it. So this is what the pediatric scorecard looks like within FIS, and I think most children's hospitals belong to the Children's Health Hospital Association. And so the idea is very simple. You can look at post-op length of stay, total length of stay. You can look at trach-specific complications, readmissions, and then your average cost. And then if you click on this button, if you have your encryption key, you can actually pull up all your cases, and then you can go back and then compare and contrast to the hospital, to the patient's EMR record. So again, I use this quite a bit, more to look at trends in comparison. And then for the NSQIP, they'll look at, they have a lot more data than this in the other scorecards. So like, did they get a chest x-ray? Was there pneumomediastinum, pneumothorax? They'll look at, did you use trach ties and suture? But again, it's only the hospitals that participate within that specific tracheostomy NSQIP component. There's also the Global Tracheostomy Collaborative. We used to be a part of it, but we stopped being a part of it because you have to have somebody enter the data, and we couldn't afford to pay for someone to enter the data. You can also use the KID database. That does require purchase, but once you own it, you have it. And so you can use that to benchmark. And then it kind of doesn't matter what you use, but just try to have some external measures for quality. Don't just rely on in-house stuff. All right, so in conclusion, pediatric tracheostomy is it's a good opportunity for quality and safety improvement. If you're interested in quality and safety, trach patients is a great place to start. We try to use high reliability organization principles, and we have been able to reduce post-op length of stay and total charges. And our partnership with the hospital made it possible. And you know, opportunities to compare outcomes with other institutions is ongoing. And thank you so much for having me. I'm happy to answer any questions. All right. Everybody still there? It's so weird. I'm trying to pull up the, let me see if I can find the, I'm going to stop screen sharing. All right. It's so weird. So my other piece of advice to everybody online, you know, in this whole COVID-19 era, put your picture up for your Zoom ID. It, like, I don't know if you saw some of the reporting out of New York City, and it showed how the people who are in the ICU, if you know, you couldn't see their face, so you're kind of like, it was very, we're used to seeing people's faces. That's the way our brains work. So when you kind of look out into the abyss, it's very weird. So anyway, I saw there's one question from Andrew. How did you get buy-in from pulmonary for the trach initiatives? We just sat down and talked to them. And again, a lot of, so, you know, how do you develop relationships with people? You know, ultimately it's by picking up the phone and talking to them. And so I have a great relationship with the pulmonologist, primarily because when they ask me when they call me, I pick up the phone. And they know that if they want me to see a patient, I see a patient. I don't give them a hard time. And I think as a result, they feel like they can trust you. And then the other thing is you try to do a good job and just take good care of the patient. And those two things will make a huge difference. The buy-in is really, it's the hospital, right? It's not that hard to get buy-in from other services because everybody wants to feel like they want to take care of these patients. But the hospital, the people with the money, they often don't want to spend money on something like this. You know, they want to spend money on the heart center, right? Because that's where they make their margins, or the NICU, or the cancer ward. So getting buy-in from the hospital was the hardest part. But I think showing them that, look, the trach patients cross every part of the hospital. And when you show them that, yeah, the trach patients are the ones that stay in the hospital the longest, then they start to see the benefit. All right, other questions? All right. All right, guys. Well, I guess